Okay, I'm going to turn it over next to Dr. Geoff Bardwell. He's an assistant professor in the School of Public Health Sciences at the University of Waterloo and a research scientist at the BC Centre on Substance Use. He is a qualitative and community-based researcher who focuses on unregulated drug use and regulated drug policies and public health interventions, primarily in small, urban, rural, remote, and Indigenous communities. His research has informed policy and programmatic changes at organizational, municipal, and provincial levels. Prior to completing his PhD, Dr. Bardwell worked at a variety of direct service roles with people who use drugs, including street outreach and housing stability positions. And I've had many opportunities to have a chat with Geoff, and our community is truly blessed to have someone with his experience and knowledge here and so willing to share. So Geoff, we'll turn it over to you.
Thanks very much. And I'm not sure what's happening, but it's not letting me. Oh, there's the start video. Okay, now everyone can see. Did I comb my hair today? Yes, I did. Okay,
you're good.
Yeah. So yeah, it's some tough acts to follow. I just want to say that I'm quite new to the region. Moved here in September from British Columbia, and I'm a recent assistant professor in the School of Public Health Sciences at UW. What I'm going to be talking about today is not really rocket science. Just want to bring to attention how research and data can help us understand what's going on here. And I put in the title publicly available data because it's not like this is anything I'm presenting to you is hidden and you'd be unable to know about it. And so part of this is I'm kind of perplexed as to, okay, we've known these things for many years. Why aren't we addressing them? So what does this data tell us? A brief look at Waterloo Region. So looking at opioid-related deaths in Waterloo Region in 2022, I think it's important to look at rates. So per capita really gives us a fuller picture of or understanding of what's going on. Of course, I don't want to minimize deaths to just numbers, but I think it's definitely important to see, okay, where are things happening, what communities are experiencing the most preventable deaths. So I want to speak briefly about housing and overdose in Ontario. So there's really this, and Kathy kind of mentioned this perception that overdose deaths occur at the street level. It's people experiencing homelessness, et cetera. And part of that is around like, the media and the stigma around substance use and really a lack of knowledge about what's going on. So we know that the majority of overdose deaths in Ontario occur indoors and mostly are private residences. So on this chart, we see 72% in private residences, 7.4% in hotel, and only 8% outdoors. So what does this mean? That means that we need to have targeted interventions where people are most at risk of overdose. And what could this look like? During my time in British Columbia, I spent a lot of time looking at housing and substance use and a variety of different interventions targeting substance use. So similarly in BC, 85% of overdose deaths occur indoors. And so really there's a need for targeted interventions in housing. And so you might ask, oh, what would this look like? Well, I can tell you some, and I've researched a lot of these and happy to talk about them in the question period. So examples, in Vancouver, the municipality funded a tenant-led naloxone training and distribution program. And so essentially they were able to use EMS data and identify the 10 buildings that had the highest number of overdose calls. And then they went into those buildings, hired people who lived there to lead training and distribution and work towards minimizing overdose deaths within those buildings. A lot of talk about CTS or supervised consumption spaces. So there's various models of these being integrated within housing. So this could be something like an informal setting or more of a clinical based setting supervised by clinical staff. There's also examples of supportive housing that have primary care clinics embedded within them. and these provide treatment and other health and social services to people. And this kind of leads to this next point is thinking about public health and healthcare in general, and how rather than requiring people to go somewhere to a clinic, it's bringing services to them. So thinking about in-reach, so programs that are going into housing and working with people on their goals, for example. And then lastly, I've been doing some research looking at safer opioid supply that's being dispensed through what's called a biometric dispensing machine. And so again, this is providing people with a safer supply of drugs in a place where they're at most risk of dying of an overdose in their housing. Michael mentioned this briefly. When we look at number of overdose deaths in the Waterloo region, we see a clear trend of looking at inhalation as being the #1 driver in terms of mode of consumption. And so 2019, so looking at the dark blue on the right, we see a clear upward trend, with injection-only overdoses a downward trend. And so what does this mean? Well, we need to address overdose risk and drug smoking. We know historically that most harm reduction and public health interventions around substance use, around illicit substance use, have targeted injection drug use. There's a lot of reasons for this. I can't get into those right now, but there's really a need to also have those that include interventions for smoking. So some of these things could be education and messaging around overdose risk and inhalation. Also having supervised consumption services that allow inhalation. We talk about treatments. You know, we can look to Europe. So the Netherlands, there were 3 random control trials looking at smokable options for opioid agonist treatments, and found 96% adherence rate. So that just means treatment is working very well. And so again, these are things, I'm not presenting anything that's really novel. These are things that have existed for several years in other communities. Really need to be thinking about how can we have similar things to address the harms in our communities. And then lastly, you know, thinking about the municipal level around policies around smoking indoors. There was in the news yesterday in Vancouver where the city council voted to lift the indoor smoking ban, so people could smoke drugs at CTS sites. And then lastly, the thing I wanted to really hone in on here is thinking about Waterloo Region. And you know, when I first moved here, trying to understand what types of programs and services exist, and I'm really seeing a lot of things like Kitchener, Waterloo, starting to develop more things in Cambridge. Well, what about other communities in our region? So thinking about all the other communities and the surrounding rural areas. And unfortunately, the context is largely unknown. We know from a research perspective, most research is based in Vancouver, Toronto, Montreal. And so because of this, and we know that what might work in Toronto might actually not work well in a smaller community. So this is really just demonstrating the need to learn from people who use drugs, as well as clinicians in these settings, to understand what might be the unique needs or the context there. What we know from elsewhere in Canada, and this just speaks to some research I've done in British Columbia, there's a variety of unique issues in rural contexts. So transportation issues, heightened stigma. So you think about a small town where everyone knows everyone's business. So yes, there's stigma against people who use drugs in larger cities, of course, but it's really different in a smaller community. A really lack of privacy and confidentiality, lack of availability of certain services, and then thinking about proximity to treatment and other health services. So yes, it's great that the region has a CTS in Kitchener, but if someone's using in Wilmot, are they going to travel to Kitchener? No, absolutely not. So, and then lastly, just thinking about clinicians that exist within these communities, because they're smaller communities, naturally, there's going to be less clinicians that have that substance use education and training. So just to conclude here, you know, again, not rocket science. We have existing data that's telling us what's happening in our region. What's missing is really immediate strategies to address these specific problems. And so really need to continue having ongoing conversations with people who use drugs and clinicians, as well as have more research in the area to better understand these contexts. And I'll end there. So thanks very much.
Geoff, thank you very much. I know you went through that quick, but you provided us with some really great information. I just a question, two. One, this, I call it the Alberta model because we hear it in Alberta, and with the recent election of the UCP, it seemed to be, I don't know if it is a policy of theirs or not, but this concept of forced treatment. Have you done any research in that area? Do you have any comments on that concept?
I can't hear Rob. I don't know if I'm frozen or if he's frozen.
Oh, can you hear me now?
Oh yeah, I can. Sorry,
Okay,
apparently my internet connection is unstable.
Yeah, no problem, no problem. So what I was getting at was just if you could comment on this concept of forced treatment, which I call it the Alberta model, just because it seems to be coming out of Alberta. And now with the UCP win, I don't know if that's going to be something that they're going to be advocating more. But do you have any research on this whole concept of forced treatment?
So I don't, but there is existing research elsewhere. I mean, forcing someone to do anything likely isn't going to lead to positive outcomes. But again, as a researcher, you know, I can only look to what existing evidence tells me. And so I can't, unfortunately, I can't really comment on that. But I think it is definitely troublesome given what we do know about forced treatment elsewhere and how effective things are. Again, really want to be meeting people where they're at. And, you know, people do want to seek treatment, but again, really need to be addressing a host of other issues, you know, before some people are ready, right?
Yeah, and just on that about getting to people where they're at, I guess, is there this tug and pull between wanting to control what's happening and also wanting to disperse to get to as many people as possible, and then losing that element of control or supervision or oversight? How do we evolve to a situation where we can branch out to serve more people? Like you mentioned, the biometric dispensary service, which seemed to be quite interesting.
Yeah, I mean, I think part of it has to do with political will, right? I mean, and not to put you on the spot. I know you're one of many counselors.
I'm trying.
But yeah, I mean, like, again, a lot of these things are like not, you know, I guess part of it has to do with thinking about novel interventions. So the biometric machine, never been implemented before. So naturally people are going to be concerned about it. And so in doing the research, like on that intervention, yeah, we're finding both good things and bad things. I mean, but when we think about other healthcare interventions beyond substance use, you're never going to find something that is perfect. You're never going to find a treatment for any condition that's going to work 100% of the time. And so I think like the unfortunate thing around thinking about harm reduction interventions is, again, similar to what Michael was talking about. They become politicized, and then people want to focus on all the bad things or the potentially things that could be wrong about them, rather than saying, oh, actually, this is the case for literally everything in healthcare. So
Geoff, just in the chat, there's a question. It says, what is the evidence for against forced treatment elsewhere?
So great question. I'll need to go to I can follow up.
You can come back.
Yeah, because so I could just disclose, I've never personally done that research, but I definitely can reach out to that person in the chat for existing
Okay,
research.
that'd be great. Thanks, Geoff.